Hello, guys, and it's our new episode of CAU podcast. And today we'll be talking about medicine.
There was a lot of new projects going on with the new hospital campus, which will be finalized in 2 years
Hopefully.
from now, hopefully. And the idea is and also to have that international European standards, Canadian, American standards to get into our hospital setting.
So, if I'm not mistaken, you're the youngest PhD taker.
What Dubai is for the Middle East can be Tashkent for Central Asia.
Because these days we have a very big problem when doctors don't actually have time to talk with patients.
Whatever you want to make it attractive to get a husband.
About all these good standards that people want to become like Victoria's Secret models, but they are taking the Ozempic. What do you think about it?
It's effective. We also know long-term effect that there are still some thyroid cancers reported as well.
Hello, guys, and it's our new episode of CAU podcast, and today we'll be talking about medicine. Today we are with Dr. Martin. Our name sounds pretty same. My name is Martain.
Nice to meet.
And you shouldn't study medical field to be interested in topic that we'll be discussing today, and it's about plastic surgery.
Yes.
And just to start and to make clear, I would like to introduce yourself shortly, briefly, and tell us how did you came to this field of medicine?
So my name is Martain Loonen. I'm a consultant plastic surgeon, born and raised in the Netherlands. I did my medical school at Utrecht University, and I also completed my Ph.D. as well in plastic surgery at Utrecht. And I did my training in Belgium, combined with Holland and the Netherlands, combined with Belgium and the Netherlands. And so I'm board certified since 2012 as a plastic surgeon. So how I came to this field, actually, I always wanted to, let's say, physically see the results of my work in medicine, which of course plastic surgery is an ideal specialty for that. And I got triggered for plastic surgery mainly during a stage actually that I had during my medical school in Utrecht. So we had about a time period of about 3 months that we were able to choose, let's say, a subject that we would like to follow, and that was like it was an anatomy course and also in upper extremity diseases and also dissection, and then also plastic surgery, hand and wrist surgery, clinical practice as well. That's how I actually got more really interested in the plastic surgery, because especially hand surgery as well, of course, is also that's also the functional aspect of it as well. And plastic surgery, plastic surgery has actually a few fields. A lot of people don't know. So we have plastic surgery, we have reconstructive surgery. That's one part of it, and then cosmetic surgery, and hand and wrist surgery. Those that are actually the three biggest fields of the plastic surgery part. So, and my background, I was trained in all the fields, and then let's say my current practice is half of my time is I spent for reconstructive surgery, some hand and wrist cases as well, and then there's reconstructive surgery after trauma, skin pathology, skin cancer, and then do the reconstructive cases for that. So there's after tumor excision, for example, we do some skin grafting, local flaps. Then reconstructive cases for breast, and then hand and wrist surgery after trauma, for example, for the nerve lesions, tendon lesion of the hand and the forearm. And then for cosmetic surgery is mainly cosmetic breast surgery, for example, breast augmentation with implants or fat transfer, also do hair loss treatments as well, eyelid surgery, and then the typical common request is tummy tuck, abdominoplasty, to remove the excess skin of the abdomen after pregnancy, for example, massive weight loss, and then liposuction, which is actually one of the most common procedures where we remove actually fat tissue in some area where there's a stubborn of fat, which patients difficult to remove that with a diet or with exercise. So that's a little bit my background.
So if I'm not mistaken, you're the youngest PhD taker.
So actually, and in that time when I already knew in my third year, fourth year of medical school, when I did this, that's at stage actually, it was in my third year, that I would like to become a plastic surgeon. But it's very difficult to become a plastic surgeon. There are only a few residency spots. Dus that are, dus when you graduate, then you have to apply for residency spots in the Netherlands or Belgium, for example. And then there are only in Holland, there were only at that time around 8 or 9 places available per year for the whole Netherlands. And sometimes there are 200, 300 students apply for such a position actually. So then I was thinking actually, okay, what can I do to set myself apart from the other potential candidates? So then I started already with research, my Ph.D. already in my third year of medicine. So I did my medical school and simultaneously I did my Ph.D. Which is a lot of work because normally a PhD is a 4-year full-time program. But I was able to finish it actually during medical school. So when I graduated in September 2016 from medical school, I already completed my PhD. I wrote it, but I had about 5 articles which are accepted or published already then. And then I did my PhD defense 5 months later after and because then I knew that can help me to get into, let's say, residency program earlier. So, and then when I applied, they said, yeah, you're eligible, but we don't have any opportunity at the University of Utrecht. But to be honest, in the whole Netherlands, actually, for the first 3 years. So then because of my recommendation of my professor in that time, they recommended me to one of the residency programs in Belgium, and that's why I got into actually relative directly after medical school. So that was luckily they actually in that time they created an extra spot outside in the normal curriculum, and at that time for the normal amount of people were eligible, let's say for the residency program. So I got into in the Belgium, and then I completed my whole residency training in Belgium, and also did a part of my residency training in Holland as well last year. So that's my journey actually.
Yeah, and that should be really hard because when you're studying, you need to focus on new things and covering new topics, but you've covered beyond that. And it's really hard. And usually a good research takes 4 to 3 years. Yeah, and you need to go different cases.
And so yeah, all my free time went into that PhD.
But it paid off at the end.
And it paid off, yes. It paid off. Also that, because I like to do research, not only teaching and research, because that's also normally a part of your PG program as well. So I was involved mainly in teaching and anatomy lessons as well. And also for some dermatological, plastic surgery related topics and general surgery topics as well at that time. So then I had my practice in the Netherlands for about 3 years. Then it was a good practice, and then I had opportunity to I had a conference in Dubai at that time, and they did some presentations, and then already that time they asked me if potential interested, but of course I had my practice in the Netherlands. But then I met my wife, and she was also a doctor, and she was practicing medicine as well in Belgium. But then she had so we had our setup there, but then unfortunately she had to go back to Poland, which was unexpected. So then I said, okay, I'm not going to stay there not going to travel back and forth constantly. So and then I went actually to Poland. She has the Polish background. And because that's Poland is a totally different situation to develop a practice as a foreigner. So, but then already they contacted me again from the Emirates if I was interested to set up a plastic surgery practice from scratch, actually, in a hospital setting. And that's how I. When she finished her stage, actually, we went to the Emirates at that time. That time in the Emirates, it was like a situation which I would a little bit compare with Tashkent actually, and, where there was a lot of new projects going on. So we have our project here at Central Asia University with a new hospital campus, which will be finalized in 2 years hopefully. And that's actually the same kind of development. A lot of exciting new developments where to implement new healthcare facilities. So that's how I had my experience as well. To set up a surgery department from scratch was only a desk and a computer. And then gradually I developed my career as a medical director, also chief clinical staff. I was involved as a healthcare consultant to advise certain investors to invest in the UAE. And I set up some more departments as well, and then I ended up in Dubai, where I was working with a group of plastic surgeons from Beverly Hills. So I was working with Dr. Paul Nassif from Botched in the US, from Dr. Andrew Orden, Dr. David Matlock. So there were big names there in the US. And then COVID came, which was in the healthcare sector.
Everyone suffered at that
Everyone suffered because in what you see and then in the UAE is that there's now, let's say, an oversupply on healthcare. So all the fields actually, from a doctor's perspective. So in Dubai have more than 400 licensed plastic surgeons, only Dubai. So I'm not talking about Abu Dhabi even. So it's a very high competitive market. So you also learn about position of marketing, which is also, I think, what Central Asia University is doing is what they do very well is the marketing aspect as well, on Instagram, social media, and also the vision. I think it's also important. If what I also learned, after you need a vision and have an end goal. If you develop a certain project,
you need to know where you're going.
You know where you're going, indeed. So, and that's a little bit the thing what sometimes happens in the UAE. It's only short-term vision to make revenue, but not the long-term vision.
No.
So, and then in Dubai, so I always missed actually in Dubai of the UAE is the combination between clinical practice, but also teaching, medical education, and research as well. That's what I'm missing. So, because in the UAE there are medical universities, but only one has actually the own university hospital. The other ones have some connections with all the hospitals where they have the students go there. But that unfortunately there were also some. Unfortunately, that combination is quite hard to find actually. Plus, also unfortunately there was some financial aspect as well there, which I decided. Actually, I was thinking, okay, I want if the opportunity would come on my path actually. Then I would definitely consider that in terms of combination to be, let's say, a professor, do research, and also medical education, have our own practice as well. And to set up, for example, a residency program. So actually, before I came here, I received an email. It was actually in my spam box, and I was just scrolling. It's by coincidence because I only scroll from time to time if there's any major messages there, and they are deleted automatically after 2 days. And then I found that they contacted me for this opportunity here at Central Asia University by coincidence actually, and it was actually directly combines and fits actually the three elements what I just discussed. And I heard also positive. My colleagues who had my colleague who was before here as not to work here, but as a tourist. He told me already this is a very promising country where a lot of investment development aspect as well. And also then I had him, of course, then also the interview with the dean and with the hospital director of Agfa Medline, and also with the vision. What they have in mind, also with the new project here and the hospital project, and hopefully in 2 years that will be ready. And the idea is, and also to have that international European standards, Canadian, American standards to get into our hospital setting, and also with our international network. Because we are now already with. For other professors as well, and there were more professors are coming to have, let's say, that international knowledge to bring that to Uzbekistan, so that the medical students don't have to go out
Sure.
Of course, maybe there are some, well, let's say, specialized areas where
Yeah.
it may need some to arrange some international stage or practice, but with the international connection that we have, we can arrange that with universities that are, for example, in Belgium or anywhere else in Europe. So that's still a bit my background and how I came here.
For example, you visited different countries like Dubai
Yeah.
and etc. And you came here, and now you're also a lecturer.
Yeah.
And if you would like to compare the system that we have here and the system that is in abroad,
Yeah.
is there any differences?
Yeah, there's the big differences actually. So actually, if you look at the training to become a medical specialist, for in this case, the surgical field, it's 6-year program. So which means that you do 2 years of general surgery, and then 4 years for plastic, or 4 years or ortho, or 4 years of urology after your 2 years of basic general surgery training. So that makes 6 years, and then after 6 years, then you can receive the title of specialist in plastic surgery, urology, or orthopedic surgery, for example. Here it's about 2 years, maybe 3 years. So that makes a difference.
Yeah.
So we also now, together with our dean, Dr. Muro, we developing residency programs as well, which we will apply at the Ministry of Health, so that for the first time we get also a residency program. We can train our own students at the Central Asian University to become medical specialists. And so then what we do actually, the program that I developed and proposed is actually that because 6-year program is like, well, it's a long program, and so they said, okay, maybe we do then a 4-year program where we then, okay, for the general surgery part, for example, plastic surgery in this case, orthopedic surgery, remove the general surgery part and then have the full 4 years program of plastic or ortho urology for our students, which means that you get the same exposure in terms of duration, but then, okay, less general surgery. So that's something like a compromise, but not a compromise, let's say, on, let's say, the specialty time that you because you still have the same amount of 4 years comparable with plastic surgery in the Netherlands or Belgium, or plastic surgery here. So so that's the idea. So that's one aspect, which is actually the duration of the medical training. That is one. Secondly, I would say that in Europe, we work with, and also in the US and Canada, it's like we work with, let's say, more like certain standards in medicine and protocols for certain, let's say, diseases or approaches to certain diseases, and then we have, let's say, in clear for medical students, but also for if you're a specialist in training, you have certain targets and goals that you have to achieve, which not only in your clinical skills, but also in your educational skills as well. So there's a whole national program for that. For example, Belgium plastic surgery training has their own national program for, let's say, your clinical requirements, what you have to achieve when you reach the last year of your 6th year of medical, for your specialist training, and also for the educational part, theoretical part as well. So that's a whole national base actually. That is all. In Netherlands have a relative comparable system as well. Yeah, and then when you graduate from the Netherlands, Germany, or Netherlands, of course they have a little bit different criteria in terms of the clinical skills and the theoretical skills that you have to need, but when you finalize your education there, you can work in the whole European Union. So that's also the idea now here, to have, let's say, that these residency programs will be based, which then I together with Dr. Muro developed, and together also Dr. Azim June from the CEO of Medline, it's like a European program with, let's say, which
their standards.
Yeah, this European standards. Which means not only for the clinical part, but also theoretical part. And also you get, of course, also a master then in specialist medicine, special medicine in plastic surgery or in orthopedics, based on the European model, based on the criteria also in the European Union in terms of the theoretical part as well. So that's what we try to implement. of course, if there's like a specific need for, and because we will get our new hospital, our university hospital after Medline already has 200 beds. Now the new hospital is 500 beds that they aim for. And if you look at the plans, also with the vision of the founder of
big
the group, and also with Mr. Cameron, our dean, that is like a state-of-the-art, world-class facility, and where also artificial intelligence will get a major, let's say, role in that. So that there's actually a combination of international knowledge combined with artificial intelligence in a very world-class facility. And the idea is also that our doctors don't have to go abroad anymore. Maybe for high specialized training, we can organize that part of the residency training, that they can go there to the US or Europe. But then that they can come back and work in a world-class facility, which is also, I think, what I think also has a potential to what Dubai is for the Middle East can be Tashkent for Central Asia in terms of for the whole region and for the surrounding countries to come from the medical, and is that the medical knowledge is here at Central Asia University Hospital. And that the knowledge is here. The students don't have to go abroad. We will train them that they can directly after their medical school have a residency program already available, so they get to finalize specialist training and stay within, let's say, Central Asia University community. So that's the idea. So the international knowledge, the artificial intelligence, and a world-class facility which provides medical service for the whole region. The region, not only Uzbekistan, because Uzbekistan has, of course, we have 35 million people here, but also for the surrounding countries. So that's actually the vision, and also
That actually sounds as a really bright vision for our university, and sounds like you are very dedicated professional.
So because I think this is because I think I see really the potential, and you have to be. The reason that I chose for Central University because I see the vision, the long-term plan that they have, also that they're dedicated to invest in that.
Sure.
And I think that long-term vision, of course, that will take some time to develop that. But let's say this is like a 5-year program that the first residents will, when they will finish their residency program, we talk about a 4-year, with 5 years from now when we start next year, hopefully. So that's a long-term vision, but I see the developments which were also in the UAE and in Dubai, and the amount of new healthcare facilities, and so I see that also more tourism. And this in a couple of years open for tourism, so that medical tourism as well. So Central Asia University and Uzbekistan in general has that potential. And so to attract patients from the area, from China, that people don't have to go to Dubai even.
Because medicine should be convenient for everyone.
Yeah,
you shouldn't go anywhere, rent an apartment, buy the tickets, go somewhere just to be treated. Everything should be.
And exactly, and that's actually what I'm saying. Also, okay, we see a lot of patients coming from countries in the Middle East going to Dubai as well, but the issue is then with some medical tourism sometimes is that of patients from Uzbekistan they go. I saw patients from Uzbekistan even in Dubai.
Yeah.
The only thing is, of course, is that how do you follow up? So if you operate these patients there, and if something happens in theory, fortunately that never happened to me, but in theory that can happen. So then the patient has to find a doctor back in Uzbekistan, and a lot of times doctors are not really happy to see patients operate somewhere else because they don't know exactly what has to be done, or so therefore to keep that knowledge because Uzbekistan has 35 million people, so we can develop things together with that. It's all teamwork. So that's also what I like to stress is that it's all teamwork. So just together with the we have very good doctors, local doctors from Uzbekistan in Akfa Medline as well, of course, together with an international expertise, and then to develop together, let's say, a unique concept. That's what I think is still not here in Central Asia. To be honest. And I know that some there are some projects elsewhere in the world, like in China, where they also have that international concept as well. But for Central Asia, it doesn't exist, as far as I know.
Hopefully we'll be the first one.
Exactly.
The first medical hub, yeah.
What's it?
And we've talked about our bright future, about your background, and now let's move and go deeply more into your specialty. We have an information that you've invented a cartilage treatment method, and that's really interesting. Could you briefly describe?
So actually, I was in the Netherlands involved in a regenerative medicine project where we did some cartilage regenerative treatments in the wrist. So for example, osteoarthritis, where there's degeneration, the tear and wear of the cartilage get thinner, and some areas you don't have cartilage anymore.
Right.
So to have some, let's say, new treatments implemented, which were also already from the orthopedic surgery came, and then from the hand wrist surgery. So I was involved in that as well, which were some treatments where to some regenerative medicine to you have a certain scale of kind of treatments that you have, but so you have, let's say, pure in terms of stem cells, we have cartilage transplantation procedures, which are mainly for the knee surgery in that time, and also then we have, of course, the joint replacement procedure. So I was involved in that aspect as well. So then now I have that regenerative medicine, which is actually now quite a lot of attention, not only in terms of for osteoarthritis or, let's say, in orthopedic surgery, but also for in cosmetic surgery as well. So we do it for hair loss treatments. We have for PRP, platelet-rich plasma, for example, where to stimulate the hair growth. We have stem cell injections as well in the scalp, or stem cell injections in joints. We have. The only thing is that it's still relatively new specialty in that way that stem cells, of course, all the focus on stem cells. The only thing with stem cells is that you need a trigger to differentiate them in the right direction. Because if you just blindly inject stem cells, so actually that whole thing that in the UAE there's a lot of opportunity, there's a lot of facilities who focus on some stem cell treatments. But why? Because that's one of the few areas in the world where it's really, let's say, allowed. Because in the US, stem cell treatments is only allowed for blood-related diseases, and that who got an FDA approval. The other ones are all off label, because there are also therapies done with stem cells, where they, for example, injected stem cells in the spine area for certain degenerative diseases, and then the spinal tumors developed, for example. Because why? Because if the stem cells get the wrong trigger, the wrong signal. Also with, for example, stem cells IV, that intravenous injections for autism, for example, that's not evidence-based. That's because these cells, they go everywhere in your body, and then you hope that they go to in the right spot where your diseased organ is, and then differentiate in the right type of cells. So now I was actually approached before I came here by a company from San Diego, actually, who and give to discuss potential collaboration ITs regarding the fact what they're doing. Actually, they are developing stem cell treatment for hair loss. So we already have that. What we do, we take some fat, or we take some blood, and then you have this certain machines which can extract these stem cells. It's called enzymatic degradation, where you extract these stem cells from your sample. But that's also which is popular. But the problem is you don't know if your stem cells are alive. You don't know how many stem cells you have. And again, it's not FDA approved, which is actually according to the US standards. So what you can do then, you bring your sample to a special laboratory, and then you do amplification of your stem cells. You have millions and millions of stem cells, and then you can inject it in the scalp, for example. Then you see some results. Also, that company, that was interesting, so a discussion, because that company, exactly what I was saying is that they're going to differentiate the stem cells. So they're busy in a program where they differentiate the stem cells into stem cells related to the to hair structures, to the papilla of the hair, where it's actually the hair growth from actually. So what they did already, these tests in mice who were bald. So they injected, it's like a scaffold. It's like if you look at the microscope, it's like with all small holes where they place some cells from skin cells related to from these mice, some human related skin type of cells, and then they added it. These specialized stem cells. So they push them actually in a certain direction, what I was saying, which are stem cells related to the hair, and then place that in that scaffold, injected these cells combination under the skin of these mice, and then the hair started growing from nothing in bald mice. So that's the future. But indeed, you have to know. So they're able now already to differentiate them. That's I think the future, to differentiate the stem cells in the right direction that you want. Not only for regenerative medicine, for example, for certain organs, for example. Already there's some groups in Belgium, for example, from where they try to do tissue engineering, in the University of Ghent, for example, where tissue engineer, when they try to develop breast tissue, for example. For example, do you have like a model, 3D model, you seed that with special cells, stem cell related cells, and try to create, let's say, tissue in the form of a breast, which you can use for breast reconstructive surgery, for example. So that is, I think, the future. And I think so that's one aspect, which is like tissue engineering, stem cell. That's one. And also, I think artificial intelligence is in that respect also a major component which can introduce a revolution into medicine, which already is doing gradually, because interestingly, medicine is still relatively slow. The implementation of artificial intelligence.
Because it's hard, these days.
Yeah, it is, and there are a few reasons for that. Because if you look at other sectors as well, and we have already self-driving cars, for example, in certain cities in the US, for example.
It should be ethically appropriate, because
that's one. If you go into, let's say, the ethical part of it, but I think if you look at the potential that there is. So I think if you look at the history of surgery, let's say, if you look at modern surgery, only started actually in the 19th century, and the first appendectomy was done in around 1885 in the US. Then antibiotics were discovered in 1928, and then modern plastic surgery, for example, as we know, because plastic surgery was not an independent specialty. It became already only an independent specialty in the 20th century. If you look at Esser, which was actually a famous Dutch plastic surgeon, the plastic surgery started as a type of war surgery. And trauma and war surgery. In the First World War, Esser was one. Well, he was actually a dentist. He was a Dutch-German physician. He was actually always a dentist, and he was starting treating war victim patients with defects, traumatic defects. And then he started implement some local flap reconstruction, and that's how plastic surgery developed. Then became an independent specialty. So it's a relatively young specialty. And if you look at surgery, the modern surgery is also not that old. I mean, the modern surgery, of course, interestingly, in plastic surgery, we still using techniques which were developed even 600 before Christ. Suchitra was an Indian surgeon who did they call it a forehead flap to reconstruct the nose. So you take a part of tissue of the forehead, you rotate that into your
upward
defect of your nose to reconstruct that. And the reason why he developed that, because as a punishment in that time, the nose was cut off of some criminals, etc. So that's how it started. Skin grafting, for example, that means that you take a thin piece of skin from one part of the body and you bring that to the other part of the body, was already in the 1600s. So, and for example, now in cosmetic surgery, for example, with the new facelift techniques, and there's the max lift, for example, or some surgeons, they call it, let's say, the deep plane facelift, or the perfect plane deep facelift, are in general all modifications of techniques which were already developed in the 60s and 70s, for example. So that's interesting. So I think so regarding that. So if you look at robotic surgery, for example, is around the 80s, and when I was a medical student, I Utrecht with one of the first Da Vinci robots. Which is actually the beginning of artificial now, the beginning of, let's say, of artificial intelligence in medicine in terms of robotic surgery. So I was myself trained as the only plastic surgeon on the Artwas iX, is a type of robot for hair transplant. There's a new type who can extract the hairs. The robot you can program; they can make the openings for your hair to transplant the hair there, and also can implement the hair to the implantation. So in the general surgery course that I teach to the students, I also mention about the history. I have a topic about the history of surgery, but also about the future of surgery, because I think that's
also interesting.
Very interesting as well. So so I show them, let's say, then of course the technology developments from the last, and the technology developments are actually from the last 20, 30 years only. Actually, this what we have. So while we look at let's say the future of surgery and the role of artificial intelligence in that, is that so now what you see, we had this if you look at modern surgery, mainly from the 19th and then the 20th century, now the last 20, 30 years, we developed more minimal invasive surgery, where instead of that we open the body with a big incision. Laparoscopic, for example, where with laparoscopic surgery they do like it's like with scopes into the abdomen, to some surgeries there, this laparoscopic surgery was one. Then the robotic surgery came, Da Vinci robot, and where we also minimally invasive have like small openings. We bring trocars, these instruments, into the abdomen, but then we control, and not with our own hands, but we control the robots, our robot arms, and they control the instruments for you. And you control the robots by like a computer station, and then what the good thing about the robot is that with the robot you eliminate actually potential human mistakes or human errors. Actually, that means that if you have a tremor, there's your fire rate, then the robot filters that out. So, and that robot is an ideal platform to implement artificial intelligence to implement revolutions in surgery. So already in 2022, there was a robot at Johns Hopkins University who was possible to suture the ends of an intestine of a pig, actually, independently without human interference. Now recently in July of this year, actually, what I think is, let's say, an amazing progress. What they did actually is that if you look at these robot surgeries, which are done for urology, to removing prostate, for example, also for colon surgery, the large intestines, for example. So what they did actually is that all these surgeries by the robots are filmed, just like as a backup to learn, to teach surgeons, or let's say if there's any complication, to learn from it. But these videos, they programmed the computer in that way that the robot was evaluating these videos and teaching itself how to do the procedures. So what they did is the robot was looking at the angle, for example, of these instruments, and based on the motion angle, the robot was able to learn itself.
Mirroring
Indeed, and learning itself how to stitch. Does you give how to stitch, elevate certain tissue, approach certain tissue. So that will be the future, and the future will be that you give the robot a task. You say, please stitch the parts of the intestines together, or that's one aspect, for example, or remove the appendix, and they can remove the appendix from the abdomen, for example. So that is one aspect, to give the robot a task, but it's going much further. That's only first step. The next step will be that through AI, the patients will complete all, let's say, the list of questions.
Yeah.
Because what we do actually, if you think about how we think as a doctor, what we do, we have a patient, we ask them certain questions, a certain checklist.
Complaints.
So what we do, these are in our minds. Or sometimes what we have, of course, in our computer screen, have certain list with questions, and we ask them. Which like checklists. Checklists also came from aviation, by the way. The way what we work in medicine, all these checklists, for example, protocols are also mainly based on aviation sector.
Yeah.
To prevent actually mistakes, to prevent that's why we do it in the OT, in the consultation. Just before the patient goes under general anesthesia, we do we do a timeout, and then we do also a timeout when the patient we are done with the operation. We do checklist, and that's all based mainly for aviation. So what I want to say is actually so that the way we think as a doctor. So if you have a patient in front of you, you ask them a certain question, abdominal pain, for example, you go in your minds, you follow that checklist, but of course you may forget a certain question. So that part can already be completely covered by artificial intelligence. That whole process. Secondly, is for example for when we internal medicine doctor, you see a certain blood test result, then you go to compare in your mind, okay, this is abnormal, this is abnormal, this is normal. So that means this combination is probably this certain disease. For example, you see, this hemoglobin is low, anemia. You see it, MCV is low. That's, for example, can be an iron deficiency, microceptary anemia, for example. So that's what you in mind. But of course, the way that we think, AI can do it the same with a much bigger database. Because the further you are in your career, you go to subspecialize, you go to your internal database in your mind will become smaller also. So that's an interesting aspect. For dermatology, it's the same. You see a certain skin lesion, a mole with certain, which you think, is that malignant? Is it benign? Or another skin disease, and then you go to compare in your mind. Okay, I've seen it before. My experience, or from the textbook, it's in your mind. That's the diagnosis, and of course that comparison, that can be perfectly done by artificial intelligence. So, which means that, and they, of course, they don't the chance that you make mistakes, or the database what you can put into that system is huge, of course. Of course, some students ask me then the question, will our job be replaced?
Very logical question.
So I think in general, with artificial intelligence, it's one general comment about it. I still definitely believe that it's not about if you're going to implement artificial intelligence in practice, because it is when.
Yes.
And when means that there will be certain apps which you can help you. For example, what you do, what I can imagine, is for example, you did some blood tests. You do make a picture of the blood tests, and then in your app, it's going to analyze. Okay, this is potential the diagnosis, and I think that that way it will. I think a doctor in about 20 years from now is able to do, let's say, for internal medicine, family medicine, for example, is able to see double the amount of patients than he's doing now. Radiology is the same. Radiology, the scans and CT scans, the computer can definitely the same, because in the radiologist in his mind compared what he knows in his mind, what he sees on the screen. Now, this artificial intelligence can do it perfectly.
Because it's pretty logical. We have a framework, you know how to work, you compare, and you see there's nothing new that you need to know.
Exactly. So the radiologist, for example, or internal medicine will be more in a later phase where they going to, the computer will give you already the results. You make the report already of your CT scan, for example, MRI, make the report, and the radiologist will be one to sign off for that. So what I always say to the students, yes, you don't see it as a threat. See it as something also where make your work as a doctor more easy.
So
to
you can
reduce,
pay attention.
make it more easy, which means that part of the administration will be taken away by artificial intelligence. Okay, now already we do, if we want, when you dictate, let's say, an operating report, you can do it with voice control, and then the types already. That's relatively simple, but it will take much more work away from you, from the admin part, because up to 40% of our work as a physician, so as administration work, which actually a lot of time.
Sure.
So that is one aspect. So admin part, but also for your clinical work, that can help you in reducing medical errors and helping you in the diagnostic process, treatment process, and reducing medical errors, which I think is very important. And I think the next phase will be that, for example, your AI system is going to say, okay, based on these results, this is potential diagnosis, this is the treatment from different sources, and we have UpToDate, for example, which is an evidence-based medicine database where the most updated treatments are there, and diagnostic process, etc. So then, of course, that AI directly said, okay, this is potential diagnosis. Get directly from the UpToDate, all the sources, the right treatments and diagnostic, what you have to do. So there's all these algorithms, for example, which are there, which you don't. I mean, I also say to the students always. I mean, I think in terms of medical, I will come later to that aspect. But I always say to the students, don't learn all these things by heart. You can. Because what you learn now in medical treatment and internal medicine, family medicine, it will be not the same as from 10 years from now, in terms of medication-wise mainly. Guidelines change. So the guidelines, you can look that up. And you can do flow charts, and the flow charts that I also teach the students, okay, this is a flow chart for example, peptic ulcer disease, which is like an ulcer in your stomach or your duodenum. Okay, so if I show them, okay, where you can find the protocols, I show them the guidelines and the steps, and the steps you have to follow, because it can be that you maybe already are stuck in a certain diagnostic process. Okay, I don't, for example, this is not an ulcer, what to do now, which steps to do now, that you can follow that protocol, which is also the same as in the aviation sector. If a certain moment of a complication happens or you're stuck with something, you follow that. So that is the aspect, I think, of artificial intelligence, and also even as a surgeon, you're going to help you. Okay, if possibly you have for example, hemoglobin is low. Now give this amount of packet cells, and give do this treatment, and also. Artificial intelligence will give you then, for example, when the patient gets discharged, already give you the right discharge forms printed for you or sent to your email. So it makes your life easier. So you can the only thing what I think important is the medical education aspect. So if you look at medical education before I started medicine, then what happened then was actually that you had different. It was not integrated. So that's also what I want to do with teaching. What I do now for the students, integrated medical education, which means that the old-fashioned program was you get anatomy from top to toe. Then a couple of months later, you get pathophysiology, how diseases develop, and then a couple months later, you get something about diagnostic and treatments, and then, which is not really that much effective sometimes because you will forget and to do
you will be able to comprehend
and to connect them. So what I also try to do also with if we do the general surgery course, for example, is that it's integrated course, which means that anatomy. So, for example, we start with, for example, appendicitis, which is inflammation of the appendix. So I show the anatomy again, repeat the anatomy, pathophysiology, how that can develop the factors, diagnostics, and then the treatments, and also in the diagnostic, which flow chart you can, and this is a stepwise approach. So, also for me. Most importantly, what I teach the students is to a systematic way of thinking. So for me, it's not about, let's say, what is the treatment for hypertension, high blood pressure, for example. No, for me, the goal is actually to teach the students to get to the diagnosis. The treatment you can always look up. Huh?
Yeah.
Okay, surgical treatment, of course, you need the skills. That's something else. But you can look that up. But to get that systematic thinking, to get to that diagnostic process, that's what I try to teach them. So, for example, when I do the exam, so we had a couple of times already exams, so which is a combination of oral and of written and oral. So, for example, what I ask is a very basic question. For example, you have a patient with acute pain in the epigastric area, which is in the stomach area. Acute, so 24 hours, fever, and patient has malaise, it doesn't feel well. And a simple question, okay, what are you going to ask in the anamnesis? Anamnesis means what you're going to ask the patient, what are you going to ask in the anamnesis. That's one. What are the parts of the physical examination of the abdomen? Basic concept. Because the thing is, if you know the anatomy, then you know also your potential diseases.
Yeah.
What mathematics is for physics, the basic actually, is anatomy for medicine in all the fields.
Yeah.
So therefore also, then in the course, I already showed them, okay, this is the abdomen, these are the different areas of the abdomen and the related organs, relative simple concept. What if you have this pain in the stomach area,
Which
what can it
organ?
be more?
Yeah.
What can it be more? That's one. Okay. So then I say, then I say, okay, which anamnesia you go to? What's your part of physical examination? What kind of additional diagnostic tests you will maybe do? And what's your differential diagnosis of actually, what's your differential diagnosis, and what is then the diagnostic process you're going to? And what is then the treatment for your potential
It gives you clinical type of thinking,
exactly.
not only conceptual.
Yeah, exactly. So that whole process that you can use, that stepwise process, systematic thinking, is I think very important. Also, what I do the students is part is we have not only, let's say, participation, how students participate during the lessons, the lectures, but then also there's the exam, but also how they call it like their own, and there's their own, it's like their own work they call it, and there's a specialized task. And what I give every student a scientific article, a review article, which means that, for example, what are the differences between laparoscopic versus robotic surgery. So I give them an article, which means that already that research is done. I take that from PubMed, which is one of the databases where we get our medical articles from. And that review article, they have to extract data, have to relative simple concept. So then I ask them, okay, present report is presented during presentation to your colleague students this article, which means that you have to extract the information from that to a certain systematic approach, introduction, methods, result discussion, and conclusions. Extract the data, present it in a clear way, because that's what you're going to do as later on during your training or your conference to learn that. To learn that, and of course it can be sometimes complex, statistics, etc. But it's more that you learn to extract the right information what you want from
water,
exactly.
all the water stuff.
Exactly. So and present that. So that's also one part. And also what I would like to do is to introduce like an MD PhD program that already can start in medical school. What I did already, interested students motivate for a PhD program. So that they also have some publications, which I think if they want to go into which if they want to do a career here, of international career, or let's say be part of teaching as well. So that's
we've started with cartilage method and ended up with different type of teachings.
Exactly.
Regarding the AI, I would also agree with you that of course AI will not fully cover the medical practitioner because it physically not possible, but the thing is that now AI is working horizontally, like it covers all the parts, but if it will cover all those things for what doctors are wasting their time, probably we will be able to develop AI vertically. For example, we have the general concept, but you can get deep into AI process and develop your own algorithm as a doctor. You will be working with AI and it will help you to save your time, Because these days we have a very big problem when doctors don't actually have time to talk with patient. They're overwhelmed. A lot of patients are coming.
Yes.
You're taking a lot of anamnesis within a day, and you need to keep all this information in your brain. And at the end of the day, you need to live your life.
Exactly. So I fully agree with you that that vertical aspect is that mean that in all the layers of the whole process, which means then this from consultation to your treatment in the hospital, your discharge and follow up, you can implement that.
Sure.
Therefore, again, I want to stress that also the students don't see it as a threat, see it as something which can make your life more easier and also make the quality of your care better and also quality of care for your patient. Because at the end, it goes all about care, this quality of care for the patient. So, in that process of artificial intelligence, is that so the next step will be to implement it in electronic healthcare, electronic health record system, which is a system where you make your notes. And you can extract your data. You can print the results. You can see what kind of the diagnostics are done, have been done. Print them, give to the patient medication, etc. So now what you see now is a little bit in the individual application developing gradually. For example, dermatology, to make a picture, and then they can already
identify what
condition it can be. For example, that's like a relative straightforward application. But now, of course, you have to implement that in electronic healthcare system, which means that if you then that computer system should warn you, okay, are you going to prescribe a certain medication, but it's not the right dose. So alarming allergies, that exists already, but still is that, I mean, depends what the hospital facility is doing. Actually, you have simple, I mean, you have the system, you have cheaper version, the more expensive version are actually more dedicated, more like say AI related process in it. That depends on the budget actually. So what you want actually is in that every step that you do, with allergies that already is there, for example, with doses that already gives you warnings that already exist, and we already implement that. We already use that that you do the right, that you don't do the right dose based on the weight, etc. So the next step is then, as we discussed, is that they are going to give you the differential diagnosis and your treatment, and put in the treatment related. And then in surgery, going to help you that you can give tasks to the robot to do certain tasks, and then help you also during if you're going to hospitalize the patient, help you as well. That they see the let's say the alarming signs. That system is able to see alarming signs based on your vital signs. For example, the nurse is putting your blood pressure, your heart rate, your respiratory rate, etc. All these aspects, your oxygen saturation, etc. levels into the system. And then that certain alarm sounds coming out, which now is not always the case, because now there's a human factor is going to evaluate alarm signs. So that is so that's one aspect. Also want to say that to the students, but also said this that it's not going to replace you fully as a doctor. Which means that yes, you can do maybe the work of 2 doctors now, and now 20 years from now you can do maybe the same amount of work of 2 doctors instead of that you
just need to know how to use this tool.
Exactly. So you need to use you need to know the tools and to implement them in your own practice. That's they have to find that out.
Ethically, of course.
Ethically, indeed. And then maybe we need now 2 doctors or 2 radiologists. But 10 years from now, we can do the same. One radiologist can do the same amount of work, see the same amount of patients. So actually, you double the amount. Actually, you can see double the amount of patients. You can do double amount of work based on that AI. And something I want to mention is that it will not replace doctors. So it means that it will not replace, because if your system is not working, if you're then you always need a human factor. So the human factor always will check. You always will check the AI system actually, which means that you have an output. For example, the CT scan. A scan was made, and from the abdomen, your computer system gives you the report, and you will control that report if there's no errors or you just briefly evaluate it.
Richard.
So you still, the human factor is still necessary to control the AI system. And if the AI system is not working, for example, what I had when the robot surgery was not working suddenly anymore, or for the hair transplant, for example, or if you have the robot surgery is not working suddenly anymore during a prostate procedure and an abdominal procedure, then you still need the manual skills to convert to a laparoscopic or an open procedure. So that's the whole thing. So you still need that backup, that human backup.
It's
and that's
irreplaceable.
exactly.
If we're about to go back to plastic surgery, what are the top procedures that are in demand these days?
So if you look at cosmetic surgery, it's definitely liposuction, which is this fat removal. They call it suction-assisted lipectomy, which is very popular. Tummy tuck, abdominoplasty, mainly after major weight loss or after pregnancies, where you remove the extra skin. And sometimes
Body lifting is called, isn't it?
yeah, body lifting. That's mainly after massive weight loss, where you do actually this it's not like say extended abdominoplasty, tummy tuck. You do it also, let's say, for the chest, breast lift as well, arm lift, thigh lift. That is popular. Breast augmentation with implants is still one of the most popular procedures as well. Breast reduction as well. And eyelid surgery, cosmetic eyelid surgery, blepharoplasty we call it.
Is there any contraindications or indications for this type of surgeries?
Now, if you look at cosmetic surgery, if you look at the concept of cosmetic surgery versus reconstructive surgery. So reconstructive surgery, then the surgeon says or give a potential outcome. Okay, this is what we can do, and this is the outcome. And then, for example, trauma, someone has a cut there, the fingers, there is, and then the surgeon, okay, this is what we can do. This is what you're going to expect, the potential outcome. And then there's more surgeon, let's say, related to the pathology that you have. But in cosmetic surgery, there's a certain image in the mind of the patients
that they want to pick up.
And some of the cosmetic surgery is also functional. For example, eyelid surgery, if you have a lot of extra skin in your upper eyelids covering the pupil of your eye, which blocks your eye, your vision, then it's not only cosmetic, because your eyelids will look better, and younger aspect, but sometimes we combine with the eyebrow to lift the eyebrow as well, not to forget the eyebrow. But also the functional aspect, your vision is not blocked anymore. That's one aspect. So, but if you look pure at cosmetic surgery, it's more that then you have to generate a surgical result according to the image what the patient has in her or his mind, which makes it sometimes difficult because the expectations are
very high.
Yeah. So I always think in cosmetic surgery, the most important thing are two things in specific for cosmetic surgery, but in plastic surgery in general, but cosmetic surgery even more, is expectations. Give realistic expectations. So now the social media is actually in that respect a disadvantage, because a lot of these photos before and after surgery are photoshopped. This patient had high expectations. You can even in your iPhone, you have a filter where you can simulate
face up.
Face up. You can simulate the rhinoplasty in yourself, or even a lot of women when they make a picture from themselves and paste on social media, they
change the size.
Exactly what they do. They change their face automatically. They do a filter on it so that their face look more, let's say, slimmed, for example, and.
The jawline,
especially the jawlines, more slim, the jawlines, which look artificial in my way. But that's how people. That's now actually a disadvantage. So then people come with a certain image from social media and said, "Give me this image," which is a lot of time unrealistic.
But it's more psychological.
Yeah, psychological. Actually, cosmetic surgery is actually a form of psychotherapy is maybe a big word, treatment, because for some patients it is a form of psychotherapy. Yeah?
Sure.
And then you hope with that cosmetic surgery that patient feels their psychological status feel better.
The quality of life.
Quality of life. So
Because of the bullying, stigma.
exactly. So that self-image,
Sure.
to give them
confidence.
the confidence. So if you look for breast augmentation, for example, the satisfaction rate is very high. People, women feel more for hair transplant, for example, and men feel they feel more confident in society to present themselves, to interact with people. So in that respect, it has also a very important psychological aspect in that aspect. Of course, up to 8-9% of the people in a cosmetic practice has body dysmorphic disorder. So you do one thing and they want another thing. It will never stop. I've seen a few of these patients, and then you have to say now stop, because and then they will. And there's like for example the nose of Michael Jackson, for example. Yeah. And like revision. Then you end up with like a natural. I think that cosmetic surgery and plastic surgery in general, there's my vision to give a natural result.
Yeah.
Which means that people say, "Oh, you look more younger, you look more refreshed," but they cannot exactly tell you what you did. Huh?
Yeah.
So and a lot of times, for example, fillers, when people have a lot of, let's say, with fat in their cheeks or fillers, looks very unnatural.
Yeah.
And then people see directly, oh, you did something.
Yeah.
But and the same is with breast implants. We have round implants, but actually the upper pole filling looks quite unnatural. They have a more, let's say, a drooping aspect.
Yeah.
Looks more natural. In the end, you have of course women who like more that artificial aspect because they like the attention.
Sure.
Because that's
Because
why.
male like it.
That now actually that's interesting what you say that, because I always say to the patient, because sometimes the male partner is there as well.
Yeah.
And then I don't ask the male. Then sometimes the male partners are going to tell me what he or she
How
wants.
to do.
And then I put that away, and I said to the female patient, "What do you want?"
Sure.
Yeah, that's the most important thing. The same is with prominent ears. So a lot of children have prominent ears, and we can correct that. And thus we can correct that, and let's say after age 4, 5, after that age, then we can correct it. But so a lot of times the parents say, "Yeah, but I want that corrected," but sometimes also the young patients as well, because they get indeed comments on school during school time, and definitely feel psychological less happy regarding that. But if the patient can, if the patient tells you, for example, yes, this is what I want, this is what I need, and I want to feel more confident. Then I would say yes. Not that someone else is saying that. Okay, I had patients in Dubai, Emirati patients who came to me and who were not married yet before the 30th, and then apparently society-wise it's a bit different. It becomes more difficult to get a partner. Yeah. So then he said, "Doctor, do whatever you want to make me attractive. You're a man. Make me everything what you make me do whatever you want to make me attractive to get a husband." I said, "No, let's change the question. What do you want?" So that's something else. Yeah. So that's two different. So reconstructive surgery, there is a certain pathology, and you as a doctor decide what the potential outcome will be. Cosmetic surgery is that the patient has a certain image, and you have to accommodate that, which is not always that easy. So therefore, give realistic expectations. That's one aspect. The second aspect, most important thing, is not only the expectations, to match the expectation, what you can. I always show non-photoshopped pictures to patients. The other aspect is patient selection, and that's a very big problem. And especially what I noticed in the Middle East, even I saw here already some patients with major complications which were preventable. So what happened is that because of course cosmetic surgery is unfortunately like a money-driven specialty, which means that every surgery a surgeon get paid, and if you have a lot of competition, like in the UE, for example, the more for the plastic surgery, what you see sometimes, unfortunately, that the standards to operate, in the case to operate, will be lowered, which means that apparently patients has a lot of complications with cosmetic surgery, not only from the UE, but also from Kuwait, in Egypt, and I mean, I don't say they are bad. Don't say about these doctors. All these doctors are bad. No, there are a few of them who lower the standards, and maybe a 95% it goes well, but the 5% it doesn't go because it goes wrong. Eh? So what happens then is, so I was apparently the patient said to me, yeah, you're on a group chat on the platform that you treat complications, because what happens is that when I was in UAE, when patients operate from abroad, it's also a complication from the US even, and we operate there, then a lot of doctors don't want to see that complication. Because they say, no, go back to your doctor. Yeah, that patient is operated in Kuwait or Egypt. So, then the patient has to be seen.
Sure.
And a lot of doctors don't want to see that. I've seen it. I've seen the surgical disasters, which could be easily prevented by patient selection. Patient selection means that you're not going to operate cosmetic surgery on patients with a BMI, which means which is your relation between your length and your body weight, which is more, let's say, than 32, 33, above. Then if you do that,
first stage of a best.
Yeah,
more than 30.
I said, what you do, that's so if you go to operate patient of a high BMI above, let's say, I personally have a maximum of about 32, 33 maximum. Of course, a bodybuilder has a high BMI, that's muscle, that's not fat.
Sure.
So that means that if you have a high BMI, which means that the patient has a lot of fat tissue, which means that if you want to do any cosmetic procedure like liposuction or Thermotech, it takes you much more time, much longer OT time, anesthesia time, much more risk of complications, and the cosmetic outcome is less. So therefore, I said to patients, first lose weight. So all these patients that I have seen, for example, what they do then is that these patients, the complication that I've seen was pure of this kind of wrong selection. For example, not only of the characteristics and the BMI, patients in smoking or diabetes patients were not well regulated, for example, and have disastrous outcome. I've seen already recently here also one patient with a complete surgical disaster. It could be prevented by the right patient selection. But of course, the problem is that in these countries, there are a lot of financial pressure from management. So what they do, they push the doctors to do these surgeries. I've seen doctors who are operating do liposuction on patients with BMI of nearly 40, which is more indication to do bariatric surgery to reduce weight instead of liposuction. And the outcome, 4 hours of operation they did, there were holes in the abdomen. You could
the skin's dry.
Exactly. There were holes in it, and then there's certain areas when hanging skin then, which can be prevented. Patient is not happy, doctor is then not happy, and that's I'm saying patient selection. That's very important. So that's if you follow and then you follow the guidelines. Follow not only your experience, you follow the guidelines. It's a patient will never blame you if you say no, not now. We operate you later. The patient will never blame you for that.
Sure.
The patient is going to blame you if you're going to operate them, giving first of all a unrealistic expectation, or you give him the patient you know that's complication going to happen, because at the end, even if your informed consent says, okay, yeah, sorry, if infection can happen, or this complication can happen, at the end, the doctor is to be blamed.
Sure.
And if you can prevent that, then don't do it.
If we're talking about the losing of body weight and etc., about all these good standards that people want to become like Victoria's Secret models, and all the famous people are not losing their weight in a normal physiological way, but they are taking the Ozempic. What do you think about it?
Oh, and what I personally think with any hype is that always be careful the long-term outcome.
Yeah.
So we have Mounjaro, Ozempic, which indeed was popularized by some Hollywood stars to lose weight in a relative short time. Before to lose weight in a short time, we had bariatric surgery, like a sleeve gastrectomy, where you move a part of the stomach, then you lose a lot of weight in a short time. Now that surgical treatment is now been replaced by these by these medications, Ozempic, Mounjaro. I know some colleagues as well who used it as well. So indeed, that it is effective. It is in that respect definitely some, let's say, who can actually for patients to can bypass surgery actually, that in that way that you don't need surgery anymore, but only that medication.
But I
the only thing exactly is that's now we'll come with the points, the complications, the long term. So now we know that some of these patients develop gastric paralysis, which means that the stomach is paralyzed. And some patients is permanent, or some patients it takes a couple of years to get back their normal. I mean, maybe we don't know because long term we don't know, but maybe it takes some years to get their function back. We also know not the long-term effect that there are still already some thyroid cancers reported as well. And of course, the pharmaceutical industry doesn't want to hear that. But yes, these things happen, and we don't know the long-term effects. And that's what I would say personally, if you would like to lose weight and it's difficult to do it in a diet version, or you don't want to do surgery, wait at least 2 years that you have some data of these outcomes, and always look at the information, which is if you're going to start any medication, looks at potential side effects, and sometimes already are some potential side effects already mentioned. Which can be substantial. Maybe it is not that common. It's already mentioned in the text in the box of the medication box
with the small tiny letters.
And that's all we see. Exactly. So we see some rare complications. Maybe indeed there can be some carcinogenic, the cancer-related complication, for example, of certain medication in general, which is rare, but it turned out later on it's more frequently than we think. Because we don't report that, because some doctors don't see the relationship with that or don't report them at the health authorities. So that's what I'm saying is that I would be more, to be honest, hesitate and look at the long-term effect at least for a couple of years before you start doing it self. It is indeed it is rather easy to lose weight in that aspect, and it's attractive, I know. But my advice is wait. Always with the new trends, wait. Until there's a certain more scientific, let's say, reports and data. Collected data on it.
Okay, I guess we're about to finish our podcast, and the last question is, we have a lot of medical school students and probably some of them would like to become a plastic surgeons. What's your personal advice and what would you like to share with them to guide them or give them some motivation to pursuing this?
So I would say stay focused. Stay focused on your goal. Okay, medicine is a long-term goal. Which means it takes you 6 years to get to become an MD, medical doctor, and then in Europe, in this respect, 6 years to become a plastic surgeon. And a lot of students, let's say, they are not able to find a residency spot. They do 2 or 3 years research, they do some clinical work, not in training, and then become a trainer. So, which means that if you really want to become a plastic surgeon or a neurosurgeon, which is also somewhat difficult to get in, stay focused on your goal, which means that yes, you will get hardship. During your residency program, you have to do on-calls, which can be hard, and you have to learn. What I want to say, I saw my colleagues who went into business school, for example. They were in Holland. They were driving leased cars. I was sitting there in the emergency department at 3 o'clock in the night to do some wound stitches, for example. That I think that can be for a lot of students the hard moments, the sacrifice moments. So what I would say is that stay focused on your goal. If you stay focused on your goal, on your end goal, it's much easier to go to the whole process, even if it's a long process. Also, that's one. So stay focused on your goals. Secondly, is your network. So, which means that if you say, I want to be a plastic surgeon at Central Asia University, come to me. then then I know that you're interested.
Yeah.
Then you can or you can do a stage,
Sure.
some clinical experience. Then you know if it's something for you or not. Yeah, but then already I know. Okay, you want to become plastic. You're interested. You're motivated. That's your goal, and then that of course that makes the selection process more easy. If you know certain professors,
Yeah.
who can help you into residency, your network, that's important. It's with everything. Network, it's in business,
Everywhere,
it's medicine as well. So stay motivated, concentrate on your goals, make contacts with the hospitals of departments where you would like to specialize in, keep up your network. Also conferences can be a network as well. Make sure that what you choose is the right for you.
Yeah.
Because in surgery, most let's say the percentage of students who change to non-specialty is quite low actually. So because interestingly, a lot of students who want to become a surgeon, they have a second choice, psychiatry. For example, in the Netherlands, which is an interesting choice. But anyway, what I want to say is that stay focused on your goal to achieve it. Always have a plan B also.
Sure.
Because that's in surgery, if you have to do a treatment, you have a plan A, but if it doesn't work out, let's say plastic surgery, because it's a bigger defect, you always need a plan B and C.
Yeah.
At the same, I think, in your choice to become a medical specialist, okay, I want to become a plastic surgeon, but if that not work out, because there's no, the residency spots are already taken in for the next couple of years, or it turned out it's not something for me, then always have a plan B or a C. Make a list for yourself. Have 3 specialties which you would like to specialize in. Go for number 1 to get in. And the most important thing, or the difficult part, is to get into a specialty, and then a high competitive specialty. And then then at least you have plan B and see what you like to do. Do something what you like. Don't do it for the money. Don't do it for financial purposes. Never do that.
Yeah.
Because you will end up being unhappy. Do something which you're really passionate about, interested. That's one. So that's your ABC choices that you have. And then when you get into one of these 3, then if you get into, of course, this is a long process. And in Europe, it's 6 years. Now we make it 4 years. That's already, let's say, a little bit more relieving, I would say. But still, you then have a good qualification, good experience, which in that field, is that these amount of years are comparable with the amount of years in Europe. And then stay focused. Stay focused on the end goal. Yes, maybe you will, and one day you say, okay, I'm tired of an operation middle of the night, or have to do a lot of administration. Well, look at that goal further. And when you reach that goal, then when you are a plastic surgeon, for example, then you have, then you will have also potential students who can you can teach, you can train, they can help you, for example, and then you achieve that goal. And then another motivation will be your subspecialization. Okay, you're a plastic surgeon or general surgeon, you go to subspecialize, and to make it for yourself maybe even more attractive. But it's a long breath, I know it, but stay focused. Choose your ABC, 3 choices that you want to do, so that you don't be disappointed if you don't get in your first choice. At least you have 2 other choices which you like. And then when you're in that choice, stay focused until the end to reach your goal, and that you become a medical specialist. And keep your network up to date.
Thank you so much, Dr. Martin.
A pleasure.
It was a really good conversation. Thank you for visiting us.
Thank you for having me here.
Thanks.